Our vaccine for Alzheimer's disease is a vaccine that makes the immune system produce antibodies against the A-beta peptide and toxic species of the A-beta peptide. So the good news is that we now know that from monoclonal antibodies that it's a validated target. So we're pretty excited about going after this validated target with a vaccine approach, which is very differentiated from a monoclonal antibody approach for many different reasons, and for cost, for convenience, and might be much better to approach prevention of Alzheimer's disease with a vaccine than a monoclonal approach. The paper that was just published is all the methods and data that we collected in a phase 2 clinical trial in early Alzheimer's disease. We designed this pretty well. It was a very small cohort, but that led to very encouraging results. So we tried 2 different treatment regimen of the same dose of our vaccine. We confirmed that first it was safe and well tolerated, and that's something that we need to confirm in a much larger patient population eventually, but so far it's been very, very encouraging on the safety and tolerability side. Something that we are pretty happy to see is that we don't see those amyloid-related imaging abnormalities, ARIA-E. We don't see that at all, and that's something that is present in up to 30% of the patients that are treated with monoclonal antibodies, perhaps because monoclonal antibodies are pretty aggressive. They reach a high concentration immediately, and we believe that a vaccine approach where there is a natural titration of the antibodies might benefit on the safety side. Now, we also showed that it was highly immunogenic. Almost all patients but one developed antibodies against the intended target. And we could also demonstrate that we could maintain steady state antibody titers with quarterly boosts. This is something that is important to know. We got excited about this. One quality of our vaccine, of course, is that it's not a permanent antibody response, and we can control the duration of the antibody expression. And knowing that we can maintain steady state by regular boosting, but if we wanted to stop individuals to produce antibodies, we would just have to stop boosting. So immunogenicity and safety were very encouraging. Now, it was very exploratory. We didn't expect any efficacy in such a small patient population. It was about 15 individuals per treatment arm. But we still looked at other biomarkers and ran several clinical scales to see if there was anything happening. And so on the cognitive scales, we were happily surprised to see that it was all going in the right direction, with up to 50% slowing of cognitive decline. This was not significant. You wouldn't expect significance with, again, such a small patient population, but all the clinical scales that we used were all showing the same effect, all going in the same direction and to the same extent. So, which is on its own very reassuring. Now, on the biomarkers, we didn't have all the tools that the field has developed over the past couple of years. When we ran the clinical trial, we didn't have those fancy assays to measure p-tau or a beta 42 to 40 ratio in plasma. Unfortunately, we couldn't collect a CSF sample in this clinical trial. So the biomarkers were mostly amyloid PET imaging, and we had functional MRI as well. So, and those two biomarkers also went in the same direction of improvement with 311. It was not significant. It was kind of almost significant for PET amyloid. And again, data going all in the same direction were very, very encouraging. The immediate implication is that we're excited about 311. The data that we collected in this phase 2 are good enough and sufficient for us to think much bigger. Now, so we want to push these programs through a much larger phase 2 clinical trial, going after Alzheimer's disease, and on the clinical development side is a big beast, and we want to partner. We want to find the right partners to help us push these through development. This is something that we are focusing on very aggressively at the moment, finding the right partners. Now, again, the immediate next step will be a much larger phase 2 to confirm some of those data and generate more hypotheses on perhaps a dosing and treatment regimen and duration of treatment and so on. Eventually, we think that like I said earlier, a vaccine against A-beta, if given early enough, even before we develop the symptoms of Alzheimer's disease, will be the most appropriate way to go after this disease. When people are diagnosed with Alzheimer's disease, there's already been a significant neuronal damage, and we hope that in the future we can prevent that damage rather than trying to fix it. And we're not going to be able to fix the damage with immunotherapies. And so we are also exploring ways of developing UB311 in the prevention context, whether it's primary prevention or secondary prevention. But this is more long-term.